this is literally like the third time I've tried to record this video. Here we go, okay? I have 4 kids and 2 hound dogs and a Yorkie. So, and apparently an Amazon man, and I don't know. Anyways, today is my 3rd day of clinical. I'm a WGU student. I'm a PMHNP student, and I'm doing my clinical preceptorship in outpatient. I'm not going to say the location, all those things, because it's not relevant. And I'm in Texas, and we're preparing for a winter storm. So that definitely was a factor today for patients, right? Because it's gloomy outside. It was a factor for me. Also, to kind of preface all of this, I didn't get good sleep last night. So that really kind of affected my own mood. I mean, I was fine, you know, we can remain professional and all those things. But definitely get sleep, because one of the things I am learning more and more as I delve into this, and granted, this is day 3, but my preceptor, she's like, I like literally have you like trying to drink water from a fire hose, and she's like, thanks for just like adapting and hanging. So I've learned, I feel like I've been there longer, but mental health is so important for us, like really important for us. Not just because you're going to meet with a patient that's going to trigger you, but just get sleep so that you have the energy, and you don't, like, when you're speaking with somebody, you don't look like a zombie, and like you're like, they're like seeing through you and you're seeing through them, and you know, your wheels don't look like they're turning. So yeah. Anyways, day 3, I'm trying to figure out, like, WGU gives us like this template, and it's great because it's what you ultimately do your assessments on. They want, like, for every hour you do a patient, and it doesn't exactly work out that way. So you've kind of got to play with that and figure that out with your preceptor. But they have this template that I highly recommend that you print out, you take with you, because you will definitely need it. And it is not a full like workup. It's not a full psych assessment. It's not the mental status exam and all of that and the H&P and stuff. It's not all that. There's just little bits of it. And it's really the way, it's the way that they can justify our clinical hours by saying we've spent this much time with these populations of people. So it's not hard to fill out. I don't feel like it's too much. I've left it all. I left 3 days, and like I left all of the entry that I need to do to like today. So I think I'm going to try to find a rhythm where I'm entering that in at least nightly, or at least every other night. Luckily in the outpatient setting I'm in, they have kind of the same patients that cycle through, and she follows them as they're doing group therapy and stuff. So that's really nice. So like if we miss something with the patient, like they're there anyways for group. So that's actually really amazing for learning. So I'm very fortunate. That will not necessarily be my next preceptor or my next rotation. So, but I am grateful for this because I think it's exactly what I need. And it's at the cadence that I need it. So I would say that, like, now that it's Friday, started on Wednesday, I would say that the biggest thing that sticks out in my mind right now, as far as like what I'm focusing on, is really gotta understand and contextualize for myself the DSM-5, okay? They're like, we're not going to know all of them, and it's not necessary for us to know all of them, but it is and it isn't. Like, in a way, like, it's important for us to like kind of be familiar, at least have heard of all of them through the DSM-5-ish, I think. But more importantly, know the ones that are like the highest rank ones, right? And what those potential differential diagnoses are. So I find myself, I'm sitting with a patient, and the patient is describing postpartum depression, but was diagnosed with bipolar. And in my head, I'm like, oh, this doesn't seem like bipolar to me. And so my preceptor's so great, taught the patient, like wrote on the board and like did the highs and the lows and everything. The patient was like, I don't think that's me. Like, that's not what I'm experiencing. And I wrote down, as we were going through the assessment, this patient's assessment, like what I thought it was before my preceptor suggested anything or thought anything. And yes, I was listening to the specific questions, lots of clarifying questions. It seems oftentimes like she is repeating herself, but she's doing that to make sure that she's as clear as possible, and that she is not leading the witness. She is not leading the, thinking this is it. you know, and slotting the patient there. So that was really, really helpful to see. And so that's when she went on to explain to me after that patient had left, that, you know, the patient will present with, you know, 1, 2, 3 different symptoms, and kind of giving you a synopsis of what's going on. And from those, you get the old cards, right? So for each one, you're doing old cards. So if they're presenting with anxiety or they're presenting with depression or whatever, you are going to do the old cards. And onset, severity, all of those things. What are the triggers for that? All of those things. And then from there, she goes, then you start kind of formulating what you think the diagnosis is and your differentials. What you think it is and what you think it within this category, you know, what you think that is, and then kind of like what some of the differentials might be, or if it is even necessary to pathologize all the symptoms that the patient is saying that hasn't been pathologized or diagnosed. So if the patient has, you know, major depressive disorder, but they're presenting with anxiety, you know, or even here's a better example is one of the patients we had today that has major depressive disorder, and she was feeling kind of anxious about the fact that her kids left, and sad as well. Like depression was still kind of happening, but it wasn't like grave depression or anything. It wasn't like an exacerbation. It was like, you know, it was kind of still in tune with her norm, but maybe a little elevated. But, you know, and she was like, you know, what can I do for that? Like, is there something that I can take for that? And my preceptor was like, no, because she's like, it's not that I'm saying no right now. She's like, I'm saying no right now because I don't want to take away from the opportunity for you to try to cope using your coping skills with something that is normal in life. Like if your family was coming to visit you or your kids were coming to visit you and you typically live alone and then they leave, like those are normal things that happen in life that we have to find a way to cope with. And so the patient really understood that. And I'm probably not explaining it very well, but she communicated that very well. And she's like, what I'm not saying is, she's like, that I'm not going to not help you or anything. She's like, however, like if, you know, the kid's leaving and you, especially with the weather the way it is, if you are experiencing even more than usual depression and like you find yourself getting worse and worse and worse and worse, please let us know ASAP so that we can get you in and we can help you with that. And we can come up with a game plan. But sometimes it is just letting a patient sit with that anxiety. Another example was a patient that had come in and was put on, oh my gosh, I can't remember the med. I can't remember so many meds right now in my head. I can't remember the med, but this patient also was experiencing some anxiety, and they were, I think, inpatient at the time, and maybe they were inpatient or outpatient. I can't remember. Sorry, there's been so many. But long story short was this patient had wanted some kind of medication for the anxiety that they were experiencing during that moment, but it had simultaneously also felt like something wasn't right. And so one of the things my preceptor pointed out to me, she's like, so what we want to do is be careful about just giving people meds. And, you know, because they're exhibiting some anxiety, sometimes you want to let that ride. And also, like, we don't want to give something like acute, like a benzo, and then sometimes that anxiety is a cue that something is not right within our body. And in this case, that anxiety that woman was experiencing, she had pneumonia. So she had to actually be sent out. So that was just a really good example of, like, you know, being judicial with, like, or being slow to, like, throw a med at it, you know, pathologize it, throw a med at it. She was anxious because she had pneumonia, and when you have pneumonia, it's difficult to breathe. So that's what she was experiencing. And kind of after, like, she explained it, after this had all happened for this woman was like, oh yeah, that's like actually a really good point. So it's like we want to give them what they need at the smallest dose that they need it to keep patients stable. And we have to be very careful about just giving meds. And I know that seems like duh, but I feel like there's situations that could come up that I might be like, oh, well, maybe we should explore anxiety medications instead of being like, what would happen if I let this ride? And, you know, if you can maybe filter that out and chew on that and be like, well, if I let this ride and this is really detrimental to the patient and I'm concerned about their safety, then maybe that's the appropriate time to do something, to intervene, whether it's therapy or stepping them up in their status, you know, putting them inpatient or something, or coming up with a plan, or increasing their medications or whatever it is, increasing meeting frequency, making sure that they have like meeting with a psychiatrist and everything that are outside, because again, this is outpatient, and so we don't do med management for patients that are in their IOP program, which is like their group programs and stuff. So, but we do it for PHP. So people, anyways, I'm not gonna get into that. So that's kind of like the biggest thing that I'm like kind of focusing on. So it's like meds, it's the administrative logistics, which is just, you know, like no matter when you work in a hospital, like, you know, when I worked at a hospital, various hospitals, whatever, you have to learn the way everything flows for admin and how you submit paperwork and all that. So, okay, the ICD codes and stuff like that. And I feel like I'm learning the CPT codes right now, and that's not like terrible. And then there's the ICD codes, which I have to get myself into. She said it would be beneficial to memorize them. And she goes, even if you don't proactively try to go memorize them, you're going to just memorize them by nature, because you're going to keep just repetition. They're going to come up. So she's like, you might as well just start having that list there and start kind of curating it in your mind. So my homework that she had for me was write down all the disease processes that you've seen through these 3 days, and write down all the meds that you've seen through these 3 days. And she's like, I really want you to try to like memorize those, like get those in your head, which I thought was a great task. Because I think overall between the 3 days, we saw 13 patients. So it wasn't like a crazy amount, but it felt like a crazy amount for me because it's new and it's not just sitting with a patient. It's like learning all of the other things that go with it. So that was clinical 3. Again, she's fantastic. She checked in with me. I think it's important for us to check in with ourselves, make sure that we're good. And you know, that was pretty much day 3. So I will return back next week. I'm looking forward to it because next week is supposed to be heavy admissions. And by next week, I won't be doing an interview, but I will be doing an interview, but it'll be a follow-up interview. So she'll have me do practice 1 follow-up interview, which, how do I feel about that right now? I don't know. I don't feel terrible about it. I have a natural curiosity. So I find myself, she even lets me interject and ask questions to the patient. I really try to think hard about the question I'm asking before I ask it, so it's not a detriment to the patient or her or the session, and I don't sound like an absolute goof off. And she has given me the feedback of like, you've asked really great questions. So she's great. She's letting me cultivate this insight and awareness. And so I look forward to next week and to see what it's like doing with these admissions and how it was doing my first follow-up interview with a patient. So hope this helps, and happy clinicals.